Hello, everyone. Nice to meet you all. My name is Joseph Wanjin Jeon. I'm a resident physician at Loma London University. And I want to especially thank all of you and MOASC for this opportunity to share this case report. Briefly, myeloproliferative neoplasms, or MPNs, can be further categorized as polycythemia vera, essential thrombocytosis, and primary myelofibrosis. They're actually all associated with deep vein thromboses, but DVTs in unusual sites, such as the portal vein, are rare. And this portal vein or other types of unusual DVTs may be the initial presentation prior to the diagnosis of MPNs. Unfortunately, the diagnosis of MPNs are delayed, which further delays treatment. And so the question we want to ask is, what types of patients should be screened for MPNs? Today's case is a 36-year-old male who presented to our institution with left upper quadrant abdominal pain for about a month and associated nausea and postprandial discomfort and fullness. When we asked the patient further, he denied any pertinent past medical history. He didn't have any history of thrombosis, and there were no risk factors such as recent trauma, personal history of cancer, liver disease, or smoking. When we saw him, the laboratory findings showed that the white blood cell count was normal at 6.24, hemoglobin of 13.5, hematocrit of 40.4, and platelet count of 185,000. And there was mild elevation in the AST-ALT to 88 and 118, ALP to 186, and a normal total bilirubin, and COVID-19 was negative. Because of his abdominal symptoms, there was a CT abdomen pelvis that was ordered. And as you can see in figure A, there was an extensive portal vein, specifically extending into the splenic and superior mesenteric veins, as you can see in this red arrow here, and associated splenomegaly of about 20 centimeters. The patient was admitted for this newly found portal vein thrombosis and started on heparin drip, and then started on apixaban with a plan for outpatient follow-up with hematology, specifically for anticoagulation. Now, when he was seen at our hematology clinic, because of his young age and such an unusual site of unprovoked DVT, a JAK2 mutation was tested. And sure enough, a JAK2 V617F mutation was positive in the serum. This led to a bone marrow aspiration and biopsy, some of the slides of which you can see in figures B, C, D, and E. I do want to point out specifically figure D, where these red arrows point to some loose clusters of megakaryocytes, and there's the figure E, which shows erythroid hyperplasia. Together with this JAK2 V617F mutation and these findings in the bone marrow, the patient was diagnosed with a myeloproliferative neoplasm, specifically polycythemia vera. And on repeat lab testing, the patient did have elevated hematocrit to 48%, and so was started on phlebotomy, therapeutic phlebotomy, daily aspirin, and continued on apixaban. Thankfully, after several months of apixaban, and the patient had a repeat ultrasound of the abdomen. And as you can see in figure F, the main portal vein does now show patency in the portal vein, signifying that the portal vein thrombus is resolved. And the patient also reported to improved symptoms of his postprandial fullness and abdominal pain. Briefly, portal vein is actually a very rare set of DVT, and put together with MPNs, the incidence of portal vein thrombosis in MPNs is as low as 1%, 1% or 1.4%, according to some authors. In general, MPNs develop from this overproduction of hematopoietic cells from driver mutations such as JAK2, KLR, and MPL. And interestingly, 92 to 95% of patients with PV are positive for this JAK2 V617F mutation. Briefly, definitive treatments for PV includes pegylated interferons and hydroxyurea, and patients who have PV should be started on therapeutic phlebotomy to keep their hematocrit less than 45%. Two brief key points are that younger patients, less than 50 years old specifically, Without apparent risk factors who present with unusual DVTs in sites such as the portal vein should be tested for JAK2 mutation, and patients with unprovoked DVTs that are associated with NPNs should continue indefinite anticoagulation. Thank you.